So can I start by thanking once again the Gerald Lee Charitable Trust for allowing us to put this event on. I'm particularly delighted to invite the next speaker, Laura Nath, who is based in the University of Adelaide. Laura is just completing a PhD there on work that she's about to describe to us, but she did spend a short while here visiting in Newmarket, so it's lovely to see a familiar face. Being slightly fearful of technological challenges, what we've done is we've recorded Laura, so we're going to play her video first, but Laura is here in the background, so after her presentation, we'll take some live questions.
Thank you very much to Professor Celia and organisers of this meeting for the opportunity to speak. I'm aware that Mr. Gerald Lee was an inspirational member of the thoroughbred racing industry, and I'm grateful to the Gerald Lee Charitable Trust for their role in supporting this lecture series. I'm an equine veterinarian based in Melbourne, Australia, and I'm coming toward the end of my PhD research, which has been focused on cardiac rhythm abnormalities in thoroughbred racehorses. Some of this research related to sudden cardiac death I will present to you today. In today's talk, I'll take you through the definition of sudden cardiac death and how the prevalence of this disease is investigated. We gain an idea of the prevalence of this disease through epidemiological studies, but importantly, a diagnosis cannot be made without a full post-mortem examination. Studies investigating risk factors have been performed, and these results can help us to understand the underlying causes of sudden cardiac death in thoroughbreds. Finally, we will briefly talk about what can be done in the prevention and further investigation of sudden cardiac death. What is sudden cardiac death? Sudden athletic death occurs when there is acute collapse and death in an otherwise healthy horse during or immediately after exercise. Sudden cardiac death is a specific subset of sudden athletic death, in which the cause is suspected to be due to a fatal cardiac rhythm abnormality. Sudden cardiac death is uncommon, but demands much attention when it does occur. These are news articles relating to Medina Spirit, who is the Kentucky Derby winner, a young 3-year-old thoroughbred colt who died in training in the USA in 2021, and Admire Rakti, who won the Caulfield Cup and was the Melbourne Cup favourite. He died in the stalls after finishing last in the race in 2014. The sudden death of a horse is devastating for the owners, trainers, jockeys and strappers, and very confronting for racing participants. These incidents have a negative impact on the public perception of the sport and on the social licence to operate. These particular cases also highlight that excellent performance does not necessarily preclude underlying cardiac disease. On the next slide, I'll show an example of a horse collapsing during the race, and I hope this is not too distressing for the audience, but I wanted to show how unsettling these incidents can be.
Under the turn, and they're off. A level break. Hibernator began well, so did Alloy, pushing forward in the early stages. Also up there vying for a leading place is City Chap. Princess Titanic not far away. Let's Rave On. Out of the red, 6 horses try to sort their order out as they drive into the first bend, and Ollie took a sit now, and Alloy's in behind those. Along with On the Running Rail, Bamboka, the Pacifier, Medikwi third last, Black Hat, and then 2 lengths away, Great Alpine Road. Well, out of the red, he's going on from the wide gate. He's going to take up the lead very shortly. Oh, there's a performance back in the field, the Pacifier. I think he might...
This study, based on research from California, was very important because it showed that jockeys are much more likely to be injured when a horse dies, with approximately 15.6% of jockeys sustaining serious injuries after these incidents. Not all fatalities occur during a race, and therefore not all fatalities are associated with falls. When this study looked at injuries associated with a horse falling during the race, they found that jockeys were injured 64% of the time. One of the difficulties in confirming the cause of death when a horse dies suddenly is that sudden cardiac death is an electrical event. This diagram shows the normal conduction of the impulse within the heart that is associated with each heartbeat. In a normal heartbeat, the impulse starts in the sinoatrial node in the atrium of the heart, propagates through the atrioventricular node, and then to the ventricles, which are the major pumping chambers. The corresponding ECG for these events is shown at the bottom of the image. A disruption anywhere along this conduction pathway can cause abnormal heartbeats, which occasionally can be fatal. Following a sudden death, lesions within the heart are rarely seen. As I mentioned on the previous slide, this is often because the structure of the heart is normal. In contrast, lesions in the pulmonary system are common. Shown here on the left is a post-mortem image of the chest of a horse with the ribs removed, showing areas of hemorrhage at the top of the lung with the heart at the lower left. In the centre is the trachea, or windpipe, which is filled with blood-tinged frothy fluid, typical of edema and hemorrhage that can occur following death. In the bottom right, we see an example of old hemorrhage, typical of repeated exercise-induced pulmonary hemorrhage episodes, alongside more acute hemorrhage at the front of the lung. In the top right, we see the normal appearance of the heart at post-mortem. Given that these lung lesions can be seen following sudden death and following euthanasia, considerable expertise are required to interpret the significance of these lesions and their relevance to the cause of death. As I've just mentioned, the normal appearance of the heart in cases of sudden death does not rule out a fatal cardiac arrhythmia as the cause of death. Occasionally, gross lesions, those being able to be seen with the naked eye, are observed, and these include right ventricular cardiomyopathy, where there is thickening of the walls of the right heart, and dilated cardiomyopathy, where there is enlargement of the heart size and thinning of the walls. An example of a grossly abnormal heart is shown in the top right. Histological lesions, which are seen through a microscope, include pale areas or areas of cell death in the heart muscle, or abnormal cellular infiltration. Abnormal cells within the heart muscle can be fibrosis or amyloid. Fibrosis is known as scarring, and mild fibrosis is common in thoroughbred horses. An example of heart tissue stained with Masson's trichrome to highlight fibrosis is shown in the bottom right. Occasionally, fibrosis might disrupt cardiac conduction and cause death. In most cases, convincing heart lesions are not seen, and a presumptive diagnosis of sudden cardiac death is made based on the absence of other causes. Many centres around the world have a program of post-mortem examination following racing fatalities. This large study from 2011 combined post-mortem records from multiple jurisdictions, including California and Pennsylvania in the USA, Melbourne and Sydney in Australia, and Hong Kong and Japan. Results from these different centres were combined to give more information about sudden death. The majority of incidents in this study occurred on race day. The study found that, for all centres, approximately half of the incidents occurred during exercise, i.e. on the racetrack during the race, and approximately half occurred post-exercise, which would include fatalities in the stalls or on the way to the stalls after the race. The major causes of sudden death were cardiac or pulmonary failure, central nervous system trauma, which includes brain hemorrhage and vertebral fractures, hemorrhagic shock, which includes vessel rupture and hemorrhage following pelvic fracture. The rates of diagnosis of pulmonary hemorrhage and failure varied depending on the institution, with California being more likely to diagnose cardiac failure or presumptive cardiac failure, and Pennsylvania and Victoria to be more likely to diagnose pulmonary failure or pulmonary hemorrhage as the cause of death. These differences likely stem from differences in interpretation of the pulmonary lesions as a cause of death. In total, approximately 30% of sudden deaths were attributed to cardiac and/or pulmonary failure, and 25% to presumptive cardiac or cardiopulmonary failure, meaning that overall 55% of deaths in this multi-centre study were attributed to cardiopulmonary failure. This is a study from Canada which included deaths from standardbreds, thoroughbreds and quarter horses. It found that fractures were the most common and sudden death was the second most common cause of death in all breeds. In thoroughbreds, sudden death accounted for 23% of fatalities, which was less than standardbreds or quarter horses. Similar to the previous study by Lyle, approximately half of the horses had cardiopulmonary lesions, and the cause of death was undetermined in 20% of cases. This diagram shows the flow of blood within the heart. Oxygenated blood, shown in red, comes from the pulmonary circulation into the left atrium, then the left ventricle and out through the aorta to supply oxygen to the brain and exercising muscles. Deoxygenated blood, shown in blue, returns to the right side of the heart through the vena cava, emptying into the right atrium, then the right ventricle, before being ejected through the pulmonary artery to the lung. If the heart stops pumping due to cardiac arrest, the blood pressure in the lungs will increase, which can cause pulmonary hemorrhage and edema. This occurs following both sudden death and euthanasia. In my view, pulmonary hemorrhage is unlikely to be a cause of death in itself, and in many of these cases showing pulmonary lesions, sudden cardiac death due to a fatal arrhythmia is likely the inciting cause. In another study from the same group in Ontario, Canada, causes of fatality occurring at any time in the horse's career were evaluated. Fatality rates in thoroughbreds were compared to standardbreds and quarter horses. Sudden death occurred in 12.81% of all fatalities, including exercising and non-exercising fatalities. Similar to the previous Ontario study, this study found that sudden death was proportionately more likely to be a cause of death in quarter horses and standardbreds than thoroughbreds. However, thoroughbreds had the highest rates of fatality overall, so the rate of sudden death fatalities of 0.376 per 1,000 race starts was higher in thoroughbreds than standardbreds and quarter horses. From this data, the group estimated that the sudden death rate for thoroughbred horses was 158 per 100,000 horse years, which is estimated to be 200 times the death rate in human athletes. Getting a bit closer to home for this audience, in this study from the UK, investigated both fatal and non-fatal cardiac events occurring in flat racing. It also identified that cardiac conditions were the second most common cause of fatality, following bone injuries. 10.2% of fatalities overall were due to cardiac conditions. This emphasises that sudden cardiac death has an important impact on horse welfare and race day incidents. Getting back to what is sudden cardiac death, we have identified from the previously mentioned international studies that sudden athletic death accounts for approximately 20% of all racing fatalities, and that sudden cardiac death specifically accounts for approximately half of all sudden athletic deaths. This is right on par with the UK study, which found cardiac conditions accounted for 10% of all racing fatalities. This study from the UK, also by Lyle and co-authors, investigated risk factors for race-associated sudden athletic death, of which we know approximately half will be due to cardiac death. In racehorses in the UK, they found that sudden death was more common in hurdle, steeplechase and national hunt racing than flat racing. They also found sudden death was more likely in summer than at other times of year. The risk of fatality increased with increasing age and increasing race distance. Horses with sudden death also had fewer starts in the 60 days prior to the fatality compared to other runners. The next study I'm going to talk about is our study from Melbourne investigating risk factors for sudden cardiac death. The risk factors for sudden death identified by Lyle were similar to risk factors for fatal catastrophic injury identified by other studies. There was a need for investigation of sudden cardiac death specifically, rather than all causes of sudden death, and to compare this to other fatal injuries. Also, fatalities in Lyle's study were racing associated. There was a need for investigation of fatalities in training. We hypothesised that risk factors for sudden cardiac death would be different to other fatal injuries when both training and racing factors, fatalities, are investigated. In Melbourne, Australia, all horses that die during racing or training have a compulsory post-mortem performed at the University of Melbourne. This program is funded by Racing Victoria and has been in place for several decades. For our study, data from 14 years were used, which included 245 fatalities. 57 horses were classified with sudden cardiac death, and these were compared to 188 horses classified with other fatal injuries. The post-mortem diagnoses are shown in this diagram, and for the sudden cardiac death group, approximately half had no lesions. Pulmonary lesions were common, and gross or histological lesions of the heart were also sometimes identified. In the other fatal injury group, most were euthanized due to catastrophic fracture or soft tissue injury. Internal hemorrhage was a cause of death in both the sudden death non-cardiac group and the euthanized horses, and other causes of sudden death non-cardiac were head and neck trauma. This graph shows the relative frequency distribution of age for all registered racing horses in green, horses with sudden cardiac death in red, and horses with other fatal injuries in blue. It can be seen from the graph that many horses in the sudden cardiac death group were 2- and 3-year-olds. The median age at the time of death for horses with sudden cardiac death was 3 years, which was younger than horses with other fatal injuries and the general population, both of which had a median age of 4 years. This table shows the results of the multivariable regression evaluating all risk factors that were assessed in the study. In the final model, we found that horses with sudden cardiac death were less likely to be entire males, were more likely to die during training, and had fewer lifetime starts compared to horses that had other fatal injuries. Medina Spirit closely mirrored the results of our study in that he was a 3-year-old that died in training relatively early in his career. He bucked the trend of our study in that he was an entire male, but in my view, this was our least important finding. At 10 lifetime starts, he was more experienced than most in our cohort. Although we found that horses with sudden cardiac death were less likely to be entire males, this probably reflects that colts and stallions are more likely to suffer catastrophic injury, which were our control group for this study. The proportion of entire males, females, and geldings in our study was similar to Lyle's study of sudden death, and about what we would expect for the general racing population. An important finding from our study was that 3/4 of all sudden cardiac death fatalities occurred during training. Clearly, horses spend proportionally more time training than racing. Therefore, there is more opportunity in terms of time for these events to occur in training. However, previous studies have identified that catastrophic injuries are more likely at high speeds, particularly those achieved during racing. Many of the horses that died of sudden cardiac death in our study were exercising at low intensity, such as trot or canter exercise. From this study, it appears that exercise intensity is less important in precipitating sudden cardiac death fatalities. The other important thing to remember is that many jurisdictions collect data on sudden cardiac death fatalities that occur at the races. but that this method greatly underestimates the overall prevalence of sudden cardiac death, and training deaths should also be considered important. In contrast to Lyle's study, which found older horses to be at higher risk of sudden athletic death, we found younger horses early in their careers were most at risk. 34% of horses in our study had sudden cardiac death prior to presenting to the races. We don't yet know why these younger horses were vulnerable. We do know that many young horses acquire viral disease when they enter training, and we have learned from COVID that human athletes recovering from this virus can have heart inflammation, which increases the risk of rhythm abnormalities. Young horses are also at high risk for bone injury because their bones have not yet adapted with the strength needed to withstand forces at speed. Horses' hearts adapt to training by getting bigger to accommodate increased blood volume. We don't know if this process might be impaired in some horses. In humans, inherited structural or non-structural diseases can precipitate sudden cardiac death in young athletes. Structural diseases include cardiac muscle abnormalities and coronary artery anomalies, or valvular disease. Non-structural abnormalities include changes in the cells which modulate electrical conduction in the heart. This bar chart is taken from a human study and shows the number of sudden deaths in athletes in relation to age in a tertiary centre in the UK over a 12-year period. It can be seen that in human athletes, fatalities also often occur early in their careers. The causes of death in young athletes less than 20 years is considered to be distinct from athletes aged 20 to 35 and those over 35 years. This chart is also taken from a study of human athletes, and it compares the cause of death in athletes less than 18 years to those aged 18 to 35 years and those older than 35 years. It can be seen that proportionally more young athletes die from sudden arrhythmic death syndrome, shown in orange, and older athletes are more likely to have left ventricular hypertrophy or scarring, shown in teal, or right ventricular cardiomyopathy, shown in yellow. Sudden arrhythmic death syndrome in many cases is associated with inherited non-structural heart disease that affects the cardiac electrical conduction. To evaluate whether inherited disorders might explain the high number of young horses in our cohort, we designed a study to investigate the heritability of sudden cardiac death. Our methods were based on a similar Canadian study investigating heritability of atrial fibrillation in standardbred horses. We identified 93 horses with sudden cardiac death from reporting of fatal incidents from all states in Australia, and all horses had post-mortem confirmation of sudden cardiac death. 465 control horses were selected randomly and were racing competitors of case horses matched for age and sex. We identified 287 first-generation sires and 553 first-generation dams. Additive genetic variance and heritability of sudden cardiac death was generated through specialised software. We found the heritability of sudden cardiac death to be 15 plus or minus 9% when assessed as a binary trait, and 24 plus or minus 12% when assessed as a continuous multifactorial trait. Heritability less than 30% is generally considered low. The heritability of sudden cardiac death in our study was lower than the heritability of exertional rhabdomyolysis, also known as tying up, and lower than epistaxis, but similar to the heritability of atrial fibrillation in standardbreds and higher than the heritability of atrial fibrillations in thoroughbreds. For sires appearing at least 5 times in the combined dataset, the frequency of their appearance in the case and control populations was compared. 16 key sires were identified, and these are listed here in the table. Of these first-generation sires, 2 occurred at a frequency significantly higher than expected compared to other stallions, with 4 or more offspring in the affected population. Notably, one of these horses was the sire of the other, and all 16 sires of interest shared many common ancestors across the 5 generations. Of the 553 unique first-generation dams appearing in the case control population, 92 mares were represented in the case dataset. 2 offspring with sudden cardiac death were foaled by the same mare. As extracted from this dam's breeding record, a total of 10 foals were born over a 13-year period. The odds of her progeny experiencing sudden cardiac death was 20%. Both offspring that had sudden cardiac death were also sired by one of the 5 sires most likely to produce offspring with sudden cardiac death. Furthermore, one offspring that did not have sudden cardiac death was retired from racing due to a cardiac arrhythmia. This gives strong evidence for a heritable cause of fatal cardiac arrhythmia in this family. So, what can be done in the prevention of sudden cardiac death? It is important to thoroughly investigate any near misses, such as staggering or collapse. Potentially also, horses with episodes of epistaxis should be thoroughly evaluated for cardiac disease. Recommended examinations would include a blood profile with cardiac troponin analysis, heart ultrasound, and resting and exercising ECG, or any other test recommended by a veterinarian. In Australia, many trainers are increasing their use of wearable ECGs, such as the Arionio Equimeter, shown here in the bottom right, and also heart rate monitors. The Equimeter is easy to apply, and when used correctly gives a diagnostic ECG even at galloping speeds. Increased use of these devices might improve the chances of observing an abnormal event and help with identification of horses vulnerable to arrhythmias. In Victoria, portable ECG devices such as the Cardia Mobile device or a LiveCore device, which capture an ECG that can be viewed through an app on a mobile phone, are currently being used by regulatory veterinarians to record an ECG in horses at the races. Some expertise is required to use the device to give a diagnostic recording. They can be used to evaluate poor performance and also determine the heart rhythm in horses that are still alive but deteriorating post-race. In the case of Admiracti back in 2014, such a device might have been extremely useful in directing therapy towards correcting the arrhythmia and possibly could have saved the life of this horse. For both the Equimeter and the mobile-based devices, recordings can be shared with colleagues and experts based remotely. As a final point, based on the chance of heart disease associated with viruses and other infections, it is important to monitor temperatures and not to exercise horses that have a fever. This is another diagram taken from a human study. The athlete's heart is a suite of changes which occur with strenuous exercise training. This is most classically appreciated as an increase in heart size. We know from research by Leslie Young in the UK that heart size increases in response to training in thoroughbred racehorses, and this allows for improved performance through enhanced blood volume and oxygen delivery. In human athletes, it has been suggested that the athlete's heart is not entirely a healthy phenomenon, and that there are parallels with pathological heart muscle diseases. We know that horses have a high prevalence of cardiac arrhythmias and sudden cardiac death, but we still do not know whether exercise training in horses might promote cardiac arrhythmias. Lyle's finding of increasing age and increasing race distance being associated with sudden death would support that exercise might promote arrhythmias, but this was not corroborated by our study. It's likely that sudden cardiac death is the final outcome of a range of underlying diseases, possibly inflammatory, genetic, or developmental. In summary, post-mortem examination is critical to determine the cause of sudden deaths. Pulmonary lesions are common in horses that die suddenly, and considerable expertise is required to interpret these findings. Young horses early in their careers are at risk of sudden cardiac death. Further studies are needed to ascertain the importance of viral disease and heart inflammation. Genome studies are needed to determine the presence and significance of heritable arrhythmic syndromes in horses. In humans, post-mortem genetic testing is used to find arrhythmic syndromes when the cause of death is not clear based on a standard examination. If specific genes are involved in horse fatalities, genetic testing might also enhance post-mortem evaluations of horses. The usefulness of industry-wide screening programs using wearable ECGs when horses enter training is yet to be evaluated, and although this might incur considerable cost, this might help reduce fatalities in the future, particularly in those younger horses. I would like to thank my supervisors, Associate Professor Samantha Franklin, Associate Professor Andre Lagersh, and Dr. Adrian Elliott. I would also like to thank co-authors on these studies, Dr. Amy Kapuzniak, Dr. Michelle Hebert, Dr. Grace Forbes, and Dr. Andrew Stent. We also appreciate the support of the University of Adelaide, Racing Victoria, and AgriFutures Australia in funding our research. Thank you also to everybody there in the audience for your attention.
Laura, thank you very much for a really comprehensive and easy to follow summary of what's known currently about sudden death. Are there any questions from the audience? While they begin to think of their questions, I wondered if you wanted to expand a little bit more on the point that you made about not exercising horses with fevers. And I think also in your summary slide, you mentioned inflammation in the heart, and I was wondering whether that comes specifically from the studies that you've done in post-mortems, or is that a kind of, you know, I don't disagree that it's a very viable explanation for some arrhythmias, but I'm just wondering where we are with kind of accumulating evidence to support that assertion.
Thanks very much, Celia. I think, I don't know how to make myself not echo.
You sound fine here, actually. So
okay.
I know it's difficult when you're listening, because the same thing happened when I was talking to you, but you sound fine.
There's sort of two questions there in regards to trying to make it a clinical assessment of whether there might be some myocardial inflammation. And I think probably in addition to our ECG and our echocardiography, possibly cardiac troponin analysis, so that's a blood test, can help with that to diagnose it acutely. Alongside those post-mortem studies that I presented today, we've also done dissections of hearts of horses that have died with sudden cardiac death, and also horses that have been euthanized with other fatal injuries, and done quite detailed histopathology looking for evidence of inflammation and fibrosis in those horses. And we found fibrosis both in the horses that died from sudden cardiac death and also in the horses with other fatal injuries. But there was quite wide variation in those sudden cardiac death horses. In some, the horses did have quite high levels of fibrosis, and you might think for those individuals that possibly some inflammation and scarring of the heart may be associated with viruses, could have contributed to that.
Thanks very much. Chris?
On the microphone.
Here's a microphone.
Thank you. Thank you very much for your talk, and it speaks volumes that I could follow it, actually, or some of it. And again, please excuse me if this is an ignorant question from an orthopedic surgeon, but I'm interested with increasing amount of data that we're getting from wearable technology, particularly wearable ECGs. Are you starting to be able to unravel in more detail the relationship between cardiac arrhythmias and incidents of epistaxis, severe epistaxis?
So probably the best information we have on that, actually some of this research I'm writing up and hoping to publish quite soon, but some of this has come from horses in Hong Kong. Yeah. So we looked at horses in Hong Kong with atrial fibrillation and also horses here in Australia. And we looked at the post-race vet exams, which, as I'm sure you know, both in Hong Kong and Melbourne will include endoscopy, post-race endoscopy, as well as auscultation. And we found that the horses that were diagnosed post-race with atrial fibrillation were more likely to have exercise-induced pulmonary hemorrhage diagnosed post-race, and also had higher grades of exercise-induced pulmonary hemorrhage post-race compared to other horses that performed poorly and had a post-race scope but were found not to have atrial fibrillation. So that was probably, quite a strong piece of evidence that there's a relationship there between atrial fibrillation and severe grades of exercise-induced pulmonary hemorrhage.
Thank you.
Simon Knapp.
Thank you very much for that informative talk. This is a bit of a basic question, I'm afraid, but we seem to picking up more, because we're looking for them, transient AF, both on the race course and in training. Seems to dissipate within 24, 48 hours. Are these horses, A, are they more prone to that again? And are they more prone to sudden cardiac death?
Yeah, thank you for that question. So I'll answer the first part, which is that, yes, even the horses that have those short-lived episodes of paroxysmal AF, we found that the recurrence rate, this is again looking in horses from Hong Kong, because they're a really good group to study because they're retained within that population. So we found that 20% of those horses that continued racing after a diagnosis of AF had a further episode in their career. And that was in horses that had, as you're saying, just a short-lived, what we described as paroxysmal episode. In horses that had a persistent episode, so needed to go into the hospital and have treatment, the recurrence rate was about 60%, so quite a lot higher in those horses that did need treatment. And in the human world, they sort of consider that atrial fibrillation is a progressive disease, in that you start with a very short-lived episode that's clinically insignificant and not detectable, and then those episodes become more frequent and of longer duration, to the point that they then get detected. And I think what we're seeing now in horses, once upon a time, we were picking up mostly these persistent episodes, so the horses that were in AF until they were given treatment to convert them to sinus rhythm. But as we're looking more closely, we're picking up these horses that are in those earlier paroxysmal stages. But generally, it is considered that it will progress under the same conditions. Then, looking at a relationship between atrial fibrillation and sudden cardiac death, I think that is, we still don't really know that yet. There certainly are some case reports of horses that have had atrial fibrillation which has deteriorated then to cardiac arrest, but that's certainly very uncommon. By far, the majority of horses with atrial fibrillation perform poorly but survive. In that group of horses from Hong Kong, I think we've had over 200 horses with atrial fibrillation, and I think we have one case that had sudden cardiac death. And when we looked at that, that wasn't higher than the background rate of sudden cardiac death, but it's such an infrequent event that, you know, if we'd had 2 horses or more, you know, possibly that would have been significant. So I think we now understand that atrial fibrillation is not entirely benign, so not entirely safe. There's, when we put the ECG on horses with atrial fibrillation at very high heart rates, they do have some changes in the shape that concerns us. But yeah, I think we still don't know whether horses that are prone to AF are more prone to sudden cardiac death.
I was quite interested to hear that you thought, or you concluded that EIPH per se as a primary problem wouldn't be a cause of sudden death on the racecourse. If I got that right, can you just explain a bit more about the thought processes behind that, please?
Or you need to have so much bleeding into the airway that the horse effectively drowns. And I think certainly there will be some cases where that's occurred, and but I suppose the point that I'm trying to get across is that the way that a large number of horses will have lesions consistent with pulmonary hemorrhage at post-mortem, and that they need to be really carefully interpreted, because sometimes we'll see these lesions in horses also that have been euthanized. And what I show in that figure is that even if you stop the heart by administration of a barbiturate, then you will still get that increase in pressure in the lungs, particularly in the setting post-exercise, where we've got really high circulating blood volume and high heart rates. So I wouldn't say that pulmonary hemorrhage is never a cause of death, but I think it can be very easily overinterpreted.
So in other words, I think the point is that if you define death as the heart stopping, that then leads to the pathology that Laura is describing, whether that death is intended or not. Is that the basic gist of it, Laura?
Yes.
I was interested in the bit where you said about the stallions. You had 2 stallions that produced 4 with a sudden death. Were they successful?
Repeat that question.
Sorry, I was interested about the stallions and the whether it was hereditary. And you said you had 2 stallions that had 4 deaths, and a mare that was by one of those stallions, or the offspring was by one of those stallions. Would you consider that, were they successful stallions? And should we be trying to take them out of the production chain?
Yeah, they were popular stallions, and so they did appear in both the having offspring with sudden cardiac death and also offspring that did not, but they were more likely, so they were overrepresented in that sudden cardiac death offspring as a sire of those. I think that perhaps, and it's very fraught, particularly with stallions, but perhaps some awareness and some then able to make more informed breeding decisions. Again, it's a very rare event, but possibly looking rather than looking at those individual stallions, more looking for genomic testing, as I heard an earlier presenter talk about as well, that if we can identify some genes possibly we might be able to stratify risk that way. I think, yeah, it was very fascinating for us to identify that one mare who had 2 of her offspring die with sudden cardiac death, and then another offspring actually identified post-race of having a cardiac arrhythmia. So I think within her family, definitely that's some really strong evidence that there was some heritable heart rhythm abnormality in that family, yeah. And possibly, I know, you know, if that was in human medicine, they would be looking at siblings and other members of the family to try to identify any heritable disease there.
And of course, in human medicines, they have genomic markers now. But your work kind of paves the way towards that, doesn't it? That's the first step,
yeah,
to identify these
yeah.
relationships.
Just a quick one. In the cohort of non-cardiac sudden death horses, there was a small number that were non-musculoskeletal, non-internal hemorrhage. What were those sudden deaths caused by?
So most of those are going to be a cervical injury, or a skull fracture, so a fall associated with spinal or skull fracture. And again, the interpretation of that is a little bit controversial as well, because, you know, what caused this horse to fall? You know, so possibly there was a medical problem there that the horse has then fallen, but we did exclude those from the sudden cardiac death group on the basis that we thought that it's these lesions of trauma explained the death. Yeah.
Thank you.
Well, if there are no more questions, I think Laura is going to try and stay with us, but we have to be mindful it is already I guess, coming on for midnight where she is. So, Laura, if we don't hear from you again, thank you very much for joining us.
No, thank you.